everybody, today we're going to discuss growth hormone and the somatotropic axis, and you'll discover that it's not only about getting taller. To begin with, what are growth hormones? Growth hormone itself has a role on tissue and bone growth, but it is not the only or final actor responsible for this process. In fact, the system is quite sophisticated. Growth hormone, or GH, is synthesized in the pituitary gland under the influence of two hormones secreted by the hypothalamus: growth hormone releasing hormone, or GHRH, and somatostatin. These hormones act as a modulation knob, GHRH cranking the volume up and somatostatin turning it down. Growth hormone is then released into the circulation, where it can either reach specific targets or continue its road to the liver to stimulate the production of insulin growth factor 1, IGF-1. Together, growth hormone and IGF-1 fulfill various important functions. Of course, as we all know, they act on bones and tissue and stimulate their growth. During puberty, the amount of GHRH increases intensely, turning the knob towards its maximum, which results in a huge production of GH and IgA1. During this period, our physical body achieves most of its growth. This process takes place when we are asleep, since GH is highly secreted during nighttime. At the end of puberty, the growth plates, areas of new bone growth in children and teens, fuse. This marks the end of growing taller. But GH and IGF-1 are secreted during our whole life, and it is not the only magic they are capable of. They also act on metabolism and promote the mobilization of energy through the use of stored fat and through the internalization of glucose in muscles. Since they support cell growth and inhibit cell death, they are also capable of black magic, contributing to certain cancers. The production of GH and IGF-1 are self-regulated. But what happens when something is wrong in the somatotropic axis? This is what we are going to see right now with the example of acromegaly. Acromegaly is a condition where growth hormone is produced in excess. This overproduction occurs after puberty, when the growth plates are already fused. If the overproduction occurs before puberty, this condition is called gigantism, as it happens during the natural growth period and influences bone size and naturally height. If you remember well, we said earlier that the closure of the growth plates marks the end in height development. Therefore, in acromegaly, individuals do not get excessively tall since their bones cannot grow, but their body is still affected. Some bones are still able to become larger and deformed, resulting in physical changes such as a flat and thick nose, a protruding lower jaw, and larger hands and feet. Indeed, unlike bones, tissue growth is not limited, which results in changes such as the development of a larger tongue and growth of cartilage in the larynx, transforming the voice. Other features are the overgrowth of lips and ears, but also teeth problems. Alongside these physical changes, as GH and IGF-1 are important in metabolism and homeostasis regulation, changes such as the development of hypertension, excessive sweating, or diabetes can develop. Acromegaly can occur at any age after puberty, but is more commonly reported to start between the age of 30 and 50 years old. The detection of this disease is generally late because the development of the characteristics takes quite some time. At the beginning, the changes are settled. But you're probably wondering, what exactly causes acromegaly? Well, in more than 95% of the case, acromegaly is caused by a non-cancerous tumor on the pituitary gland called an adenoma. This adenoma secretes GH and is the cause of the problems discussed previously. The main risk with this tumor is, depending on its size and its localization, that it compresses the optic nerve, causing vision problems, and when this happens, surgery is needed. But luckily, most of the time, the growth of these adenoma is slow. When the patients and their relatives start noticing the physical features of acromegaly, a diagnosis has to be confirmed. This diagnosis involves two parts. First, the patient goes to a biological analysis lab, where the doctors will search for an elevated production of IGF-1. Then, to confirm the diagnosis, the patients eat sugar and get his or her GH level measured 2 hours after. If these levels don't decrease, it is indeed acromegaly. And clinical imaging can be useful to verify that the tumor will not compress the optic nerve. What kind of treatments are there? Acromegaly can be treated in different ways. First, using pharmaceutical drugs by either blocking the growth hormone receptors, targeting dopamine receptors, or giving a synthetic form of somatostatin, the anti-GH hormone. And secondly, by surgery or radiosurgery if the adenoma is compressing the optic nerve and needs to be removed. Now that you know a lot about growth hormones, we'd like to end this video by presenting you some interesting and unexpected effects of growth hormone, showing how studying a disorder can help to discover secrets about hormonal functions. Growth hormone and IGF-1 are able to reach the brain, where there are receptors for them in many areas associated with learning and memory. But what does that imply when it comes to their role on cognition? Studies on somatotropic disorders have shown that patients with acromegaly showed impaired memory, and these alterations lasted long after starting a treatment. Patients that were deficient in GH also displayed impaired memory, but additionally yielded lower scores on IQ and attention tests and had a longer reaction time. However, treatment is able to bring improvement to these patients. These studies show us that GH is important for cognitive function and has to be finely tuned. If there is too much or too low, cognitive performances decrease. Now you know pretty much everything important about GH, where it comes from, how it is controlled, and even a bit about what happens when our brain loses control. So thank you for watching, and we hope that you enjoyed the video.